Professor Mehra needs no introduction at all. He is well-known figure internationally and nationally. Sir has, not only established this department of immunology in AIIMS, but he has also helped at the private sector, the edgeless diagnosis. He has established a wonderful center for HLA and COE. Sir, I am also one of the student of Sir, so it's an honor. Sir, over to you. Sir will be speaking on next generation diagnostic marker for antibody-mediated rejection in kidney transplant. Over to you, sir.
Thank you, Yogendra. Thank you very much. I thought I'll talk to this very learned group about the next generation diagnostic markers for AMR in kidney transplantation. And as you know, you already know that there are two challenges that we face from the laboratory point of view: matching and antibody characterization. And HLA genes, you know, they're very highly polymorphic. In recent years, of course, we have the NGS-based typing, so the ambiguities are gone. Antibody characterization is a very important issue. And even though we have introduction of Luminex solid phase assay, the technology is still undergoing changes and improvements. And there are current limitations of the bead assays. The limitations are not all HLA proteins or alleles are represented. This is particularly true of populations like India, which has a number of novel alleles. So not all HLA beads have the same amount of antigen on their surface. There are biased estimates of MFI. HLA antigen on the bead surface can be denatured, leading to false positive or false negative reactions. And you've seen this vicious cycle of HLA mismatch transplants and the ABMR. Here is a kidney transplant failure case. Can I use this one? Okay, and anyway, I just follow from this. And waiting on dialysis, first transplant, the guy is non-sensitized, you give him a mismatch transplant, there are de novo development of antibodies post-transplant, AMR, kidney transplant failure, comes back to dialysis, second transplant gets sensitized, again AMR, kidney failure, and the third transplant, and the patient dies. This is a vicious circle that we have. And this actually has patient impacts because you need to use increased immunosuppression, there are more side effects, increased comorbidities, reduced quality of life and things of that sort. What is the solution? The solution is avoid as much as you can donor-recipient HLA mismatching, look for the permissible mismatching algorithm, and routine and regular screening for antibodies. And in the modern era of immunosuppression, should we revisit HLA matching? My team, when I was still in AIIMS, we looked into all the literature, and our finding was good HLA match is the best because it leads to the lower grades of sensitization on one hand, lower risk of de novo development of antibodies on the other, and lower dosages of immunosuppressive agents. So you therefore avoid all those side effects, and at the end of the day, you have improved graft survival. But HLA matching also known to prevent the induction of donor-specific antibodies and will improve graft survival. The problem is that the system is very polymorphic, and as of July 7, 2022, last year, as you can see, about 34,000 alleles are known, and many more now, which means many patients will get transplanted with an HLA mismatched donor. The good thing is that not every HLA mismatch leads to antibody response and therefore graft loss. The big question, however, it remains even now, which patients will do well and which not. And this is a twin challenge that we have. Identification of non-immunogenic HLA mismatches which do not lead to antibody formation in an individual patient. And how do we develop tools to differentiate between pathologic and inert antibodies? And we have seen that the polymorphism of HLA is even more in the Indian population. And I give you one example here for HLA-A2 or B27. There are a number of novel alleles that we find not found in the Western population. So they're not going to be represented on the beads that you have. And then there's the issue of cross-reactive HLA antibodies there. Here, a patient transplanted with the HLA-B57 mismatched donor developed de novo antibodies not only against B57, but other alleles like the A2, the A23, and B58. This is because of the cross-reactivity between all of these antigens there. And these are the three technologies that we use in the laboratory. You're all very familiar with: CDC, flow, and solid assays. I want to just highlight that the flow seems to have gained grounds, and probably we had earlier reported that only when the MFI, our own study done in AIIMS, where we were trying to compare these three tools, only when the MFI reaches about 3,000 that the flow will turn out to be positive, and this figure goes to 7,000 for this CDC cross-match. Here is a study which came up just 2 years ago, and indicating that patients which the flow cytometric cross-match negative compared to the positive group, of course, and you can see patients with flow cross-match positive have significantly higher immunodominant DSA MFI compared to those that were negative there. But that's not the case in every case, because you can see also there are people in the flow negative group as well whose MFI is very high. So I think one has to deal from the case-to-case point of view. We have done studies in AIIMS to look for the complement binding antibodies. This is a study done on the C1q fixing donor antibodies over there. The study involved 206 primary LRD donor transplants whose DSA evaluated on Luminex platform on various days post-transplantation over there. 18 were found to be DSA positive, and 14 of them had the C1q antibodies. So complement binding antibodies also would actually relate to the AMR. Here is another study which just came up last year, DSA and C3D status. Probability, this is in heart transplant, and I think the summary of this study is French study, 282 patients between 2010 to 12, DSA when binding complement were associated with the worst clinical outcome. So complement binding antibodies again have been found to be bad. Now, diagnosing allograft rejection is a challenge. The pathology of allograft rejection is not consistent. Antibodies are the cause of the graft loss, we know, but their exact characterization and stratification into inert and deleterious antibodies is challenging. There is an unmet need to develop objective tests for timely diagnosis of all categories of graft loss. So therefore, can we look at the biomarkers? And given the limitations of biopsies, the non-invasive genomic-based allograft monitoring and rejection appears to be a promising tool. In this context, you could use mimic-A antibody screening, because there are a lot of patients who do not have any evidence of HLA-DSA, but yet graft is lost, and that's probably due to the mimic-A antibody. Circulating donor-derived cell-free DNA is a new kid on the block. And this is something that I want to talk about. And of course, the urinary biomarkers as well. Now, MIC-A has been known to be a novel histocompatibility locus in solid organ transplantation. We have done a number of studies in AIIMS, and they all indicated, yes, sometimes you can have donor-specific MIC-A antibodies as well. Because if you do the MIC-A allele typing, they turn out to be donor-specific. Now, we had shown this many years ago in 2007 that patients who had both antibodies, HLA as well as MIC-A, are likely to have a much worse graft survival compared to the both negative group or compared to one positive group, either HLA or the MIC-A. And this is another study which came from 𝐊 group in France last year, indicating the same thing, that the preformed pre-transplant DSA as well as the post-transplant DSA, if the DSA is against both the MIC-A allele as well as the HLA, the graft loss is significant. So there's a significant difference between all of these three groups. Now I want to come to the liquid biopsy approach for non-invasive monitoring of allograft ABMR. It's like a coming age of a cell-free DNA, something that we had known in tumors. And you can see the publications of cell-free DNA and the solid organ transplantation is increasing, particularly from 2016. But again, the total publications are still not as much. We need to really generate more data on this. What is cell-free DNA? It's a circulating free DNA, the degraded DNA fragments released into the blood plasma, used to describe various forms of DNA freely circulating in the bloodstream, including the tumor, where you call it a ctDNA or cell-free fetal DNA, CFF DNA or the donor-derived, which is what we use in kidney transplant. Majority of the cell-free DNA fragments are small, 150 to 180 base pairs, and they're released in the bloodstream as a result of the apoptotic cell death. Elevated levels of cell-free DNA have been reported in cancer, have been reported in congenital fetal malformation, and now also in allograft injury. An important issue over here, of course, is the collection of this specimen, processing of this specimen. Important because of the cell-free DNA is unstable and often occurs in low quantities. And if you do not use a very good technology, you can get false positive, the false negative results. So you need to use this specialized DNA stabilization tubes, which come from Roche or Paxi or the QIAGENE. EDTA tubes can be used, but they're not really very good because they do not maintain the stability. Now, what is this donor-derived cfDNA that we are talking about all the time? It's a transplant biomarker. Here is a patient with a transplanted with kidney, healthy organ. The donor-derived DNA is very little. Subclinical disease, that's where you want to look for. Subclinical disease in the damaged organs. You see the red sort of DNA bars, which are from the donor, are increasing both in the subclinical stage as well as the damaged organ. And you could do a longitudinal kind of a screening for the DDC and DNA there, and look for, your target is to looking for people who have a subclinical disease which is not evident through the creatinine screening or even by biopsy. And here is this diagnosing allograft rejection. This is a heart heart transplant. In the pre-transplant stage, you do the SNP genotyping of both the donor as well as the recipient there. And during the transplant, after the transplant is done, you can see the cell-free DNA is released into the plasma, very low levels though, and this fraction of donor-derived DNA circulation can be calculated. And since the pathology of rejection is inconsistent, genomic-based detection of rejection could be a promising tool. We keep saying it could be a promising tool. And if you compare the liquid versus the tissue biopsy, there are a lot of real differences over there. This is a slide from the Western group, and they think that the tissue biopsy costs are high, perhaps not here in India, and the liquid biopsy costs are low. That's not also true. I think the liquid biopsy costs also in India are high, in fact higher than the tissue biopsy. This is the area that we have to work on and look into the treatment, monitoring usefulness of the liquid biopsy. I want to show you a few sort of studies that came up in 2017 from the University of Pennsylvania, and here they have looked into 102 kidney transplant recipients and looked at the plasma levels of the ddCfDNA showing any rejection or not. And the positive and the negative predictive values were calculated. Results indicate that ddCfDNA may be used to assess allograft rejection and injury, and levels below 1% reflect the absence of active rejection and indicative and more than one. So I think the most important part is the lower levels indicate absence of any rejection. I'm not very sure yet of the more than one, although it does indicate in case-to-case active rejection. This is that same study by this group, Bloom et al. You can see the red part are the ones which are actually, there are more red sort of spots in the ABMR where the levels have gone more than 1% there. And if you compare the ddCfDNA discriminates active rejection. Of course, this study indicated no rejection group, active rejection group. You can see that there is a statistical significant difference, which is not the case if you look only the serum creatinine over there. Yet, the sensitivity and the specificity of this test is still low. I think we need to improve on that. And if you look at the NPV, the negative predictive value, or the positive predictive value, the positive predictive value is even lower than the NPV. Clinical outcomes from the assessing donor-derived cell-free DNA monitoring insights of kidney allograft. This is another study, multicentric. It just came up last year, a large study of 1092 individuals, and their aim was to investigate if ddCF DNA could identify subclinical allograft injury, and these patients were monitored over a 3-year time period. Elevated levels were significantly correlated, and these were associated with nearly 3-fold increase in the risk development of donor-derived or de novo BASS. And routine monitoring, they said, could actually identify, could be useful as finding the important graft injury. More importantly, persistently low levels may accurately identify allograft quiescence or absence of injury, and thus avoidance of immunosuppression. This is a box and whisker plot of the same study. Look at the no rejection, the rejection group over there, 0.23% in patients with no rejection compared to 1.6, and anything more than 1 is known to be associated with rejection. Now, these are few studies that have been done. I think you miscalculated the time. I had 25 minutes, you gave me 15 minutes. So please remain quiet. And therefore, the other slide, free from donor-derived DSA versus ddCF DNA levels there. So I think what this study is indicating, patients who had more than 1% of the DD-derived DNA levels over there, you can actually predict the presence of de novo development of donor-specific antibodies. Another study, this was a top 5 paper which came up in ESOT in 2021, because first time they were looking at the diagnostic value of this test to predict AMR in donor-specific antibody positive renal allograft recipients, if the antibodies are already there. And this study highlight was about half of the DSA positive recipients had ABMR, which you also will see, and display high levels of donor-derived CFD DNA levels. So therefore, monitoring of cell-free DNA in patients positive for DSAs may be a useful tool to detect ABMR and other types of injury. And this is the data. What is more important is, on the right side, you can see that this test could actually differentiate between active ABMR compared to the inactive one. But there are a number of factors which influence the CFD levels there. And normal variations could be due to age, the BMI of the individual. If the guy has done some exercises and you take the sample at that time, clinical variation, the patient has sepsis or is on chemotherapy or is on dialysis, and there are lab variations as well, which I already talked about, the sample collection, sample storage, and sample shipping. So I think all of these will have to be really looked into. The last 2 slides I want to show you about another study which our friend in University of California, San Francisco, Mini Sarwal is doing. She, rather than looking into a biomarker in the blood, she's looking into urine, because it's so easy to get that. And urine as the direct renal ultrafiltrate can be obtained non-invasively, directly reflects intrarenal processes over there. And what she has done is, again, looking at the gene expression score and trying to say the take-home message from their study is that the cell state transcriptional information could help define a clinically stable graft into histological versus molecularly stable category. Something that you think is a histologically stable may not be, because the molecular tool will show you that it's not. So this test, what they call QSANT testing, in the urine, serial monitoring with this could identify subclinical injury. And that's a very important part. But at this point of time, this test is still in an investigational stage, because the track aggression over time has helped them to look into the QSANT score. The Q score, as they call, the Q score below 32 is associated with a minimal immunosuppression, leading to a minimal risk of infection and of cancers. And you can see the lower part of this slide. You look at the gene expression score, compare the histology with biopsy, and with this molecular tool, the microarray based tools, and they've looked into transcriptomics and all. and then look into the Q score of below the 32, it's a stable graft, both from the histology point of view as well as the molecular point of view. But the Q score between 32 to 55, that's the gray area over there, where histology shows stable, molecular shows no. This is a guy who could actually go into acute rejection, so therefore there's a need to monitor and treat. Of course, the more than 55, it is always associated with the acute rejection. I think the yellow group is the one that is being targeted by this test, and hopefully in a few years' time, it might see the light of the day. Well, my summary is that the ddCF DNA, whether you take from the blood or from the urine, appears to be a promising non-invasive diagnostic and monitoring tool for early detection of ABMR, monitoring response to treatment, as well as identifying a proportion of immune quiescent individuals who may benefit from immunosuppression minimization. You don't need to give any immunosuppression to them. That's a very important part of the summary of these tests, actually. And we need to really do more studies to confirm if that is the case in your center as well. The clinical use relies on the sensitivity of the assay, while elevated levels are not specific for organ rejection and depend from case to case. Very low levels can have excellent NPV. That's the most important part. An important limitation, as I said, is to produce enough yield of this DNA and maintenance of what we call as cell-free DNA integrity. The cost factor would come over there. Further improvements in NGS-based screening tests could enhance performance characteristics, including accuracy, sensitivity, specificity, cost, and more importantly, turnaround time. Thank you very much. I want to acknowledge all my colleagues, students, a lot of my friends in nephrology, and we have worked for years on these tools in the laboratory, and together it has been a great learning experience. And we want to also thank a number of funding agencies as well. Thank you very much.
Thank you, sir. Thank you very much. It was very enlightening talk, and you touched very important parameters like cell-free DNA and 𝐸 antibodies. And sir, just a suggestion from you, where we stand in cell-free DNA in India, we are not doing regular screening for cell-free DNA, and there is no cutoff values as such. Second point is, the 𝐸 antibodies, non-HLA antibodies, we are not regularly screening those patients for non-HLA antibodies, and then we lead into the rejection episodes later on. Should we include this in a screening program for every patient, or we should selectively do that?
Well, if you use this particular test, you don't have to use it only in one go, one time point. It has to be really followed up, and there the cost factor will come. Cost factor will come particularly in the Indian setting over there. You need to do cell-free DNA at every point of time. At this stage, I have no hesitation to say screening for antibodies post-transplant is the best thing. And we need to do a study where maybe many centers can join actually and do a multicentric study. Take patients with antibodies, the de novo development of antibodies post-transplant, take that particular group of various MFI levels of antibodies, and then look for this CF DNA as well, and that might give us some clue actually. But repeating this test many times is going to increase your cost factor, and you may not get better information than this.
Right.
As I said, NPV is the most important, negative predictive value. Is test में if the ddCF DNA is below 1, then it is safer, and the guy will not need any immunosuppression.
All right. With that, with respect to time, I would like to thank the chairperson and the speaker. Thank you so much, sir.